Okay, so our next presenter is Jamie Swietlikowski. Did I get that right? All right. Okay. She is a certified nurse midwife and a nurse practitioner in the women's health. She has been practicing midwifery for 9 years. She serves as faculty instructor in the Department of Obstetrics and Gynecology and Reproductive Science in the University of Maryland School of Medicine, as well as an adjunct faculty for the nurse midwifery nurse practitioner in women's health program at Georgetown University. She has a special interest in providing and advocating for compassionate, evidence-based, quality health care for women with substance use disorders and incarcerated women. Jamie co-authored a publication titled Pain Management of Pregnant Women with Opioid Use Disorders, and she's going to talk about some of the results from that study today. So please welcome Jamie.
Hi, good afternoon. I'm going to do the best I can to get through this in a short amount of time. If you have any questions after, you can find me, I'll be here. So, I don't have any disclosures. My hope today, the learning objectives, is really to anchor the discussion in health terms. And that's what you've been hearing throughout the day, is to really drive home the concept of it's a chronic treatable condition and seeing it as such. And when you do that, especially for pain, what we're going to talk about is the pathophysiologic experience of pain for patients with opioid use disorders. And once you understand the experience of these women, I think it helps to promote some compassion towards women and promote that patient provider relationship. So, and then I'm going to show you some of the updated evidence on providing pain management for patients with opioid disorders in the inpatient and postpartum period. But I'm just going to show you where to get that information because of time purposes. We won't really have the time to go through all of it. So, what you're seeing here that's being cut off, but is what you've heard earlier today, that the number one cause of maternal death in Maryland for the last 4 years running is overdose. And that overdose we're seeing is happening somewhere between that day 30 and day 300 postpartum. So the untreated pain is a significant risk for relapse in this patient population. From the literature that I reviewed, we found 4 themes of the challenges related to caring for pain in patients with opioid use disorder, specifically mothers. And it are these 4: opioid tolerance, opioid cross-tolerance, hyperalgesia, and provider bias and misconception. So the opioid tolerance, all that means is that patients with an opioid use disorder who are actively using opioids, who are on a maintenance therapy, or even those who have a history of opioid use disorder will have a tolerance built up. And they may require a larger dose to address their pain than their opioid-naive counterparts. Opioid cross-tolerance, this is when you see there are some drugs, specifically one of the studies looked at methadone and morphine. So patients on methadone, when they were given 5 times the amount of morphine to address, their pain was still not addressed versus those that are opioid naive. And obviously this is a concern because of the CNS and respiratory depression. So this is where you see a lot of that hesitancy from providers to continue to increase their dose, especially in obstetrics, because this is not where we feel the most comfortable. And then there's hyperalgesia. So hyperalgesia, I think, And as far as interdisciplinary practice goes, this is helpful for everyone to learn. Hyperalgesia is the patients with an opioid use disorder who are actively using, who are on a maintenance medication, or any time in their life have had chronically used opioids. They will have a higher sensitivity to pain and a lower threshold for pain. So if you've ever seen a patient with an opioid use disorder come into labor and delivery, it tends to be what appears to be a very exaggerated response to the pain. This is a pathophysiologic response. The response is actually what they're feeling. And when we approach the patient, it is our job to treat them as such and not that they are drug seeking. So they do have they experience the pain more intensely and sooner than patients who are opioid naive. So this one you've been hearing a lot in the pain management. We don't escape it. So preconceived beliefs and ideas from providers are negatively affecting the pain management for mothers with opioid use disorders. The good news is there's a study that shows with provider education that you'll see some of this negative effect be diminished. So if you can get into units and educate on the basic science of opioid use disorders and what the patient is experiencing, then you'll see some of this impact diminish. So these are some of the common misconceptions that have been out there when it comes to pain management for women with opioid use disorders. What we found is that when you administer opioids appropriately for acute pain, so that means a short-acting opioid for a short course of time, you are improving their outcomes. Because by undertreating your pain, that's when you find that the patients will self-medicate, and you put them at a higher risk for overdose in that setting. Another point to drive home, opioid maintenance therapy, it gets confusing because buprenorphine, it's used in pain clinics for pain. There are different doses and a different way that it's being prescribed. When opioid use disorders are being treated with methadone or buprenorphine, the goal is to get rid of their withdrawal symptoms and ameliorate the cravings, but with minimal euphoric effect. So it is not treating their pain. When a patient comes in to labor and delivery or during the postpartum period, it is extremely important that they stay on their medication, and it is not considered part of their pain management plan in any way. And then opioid-dependent patients reporting acute pain are usually drug-seeking. And I'll address this in the postpartum part. There's a great study that debunks this. So just a quick note, the managing pain in the inpatient setting, it starts before they walk in the door. If you can get them into care, we find that when their mental health is handled, not handled, but when they're in mental health care, they have good sleep hygiene and smoking cessation, all will decrease the dose requirements for these patients in the inpatient setting. So, and there's a lot of interesting research on the overlapping of the pathways of physical and emotional pain. So it's not surprising that when a patient who has had extreme trauma or has a mental health disorder, when they take an opioid, that they get a similar relief if they're running through the same pathways. Sleep hygiene, obviously, if you're homeless, this is extremely difficult. And then the smoking cessation also disrupts your sleep. So when you can address some of these, when they come in the door, they might have a decreased dose requirement. Nicotine in particular, also it contributes to that hyperalgesia. So you have people who have a nicotine dependence have a higher sensitivity to pain. There's also, they find a cross-tolerance between nicotine and morphine. So people who smoke will require higher doses of morphine to get the same result as someone who's opioid naive. One of the things that can be done is obviously smoking cessation programs before they come in the door, and also offering a nicotine patch when they come in the door, who has been seen in a non-pregnant population to decrease their opioid requirements. The interdisciplinary antepartum pain plan, this is a great tool, and there's the SAMHSA guidelines that it came out in 2018 strongly recommend the pain plan, and it is an interdisciplinary tool where you have laid out for the patient their plans for pain, who to call to verify their dose for their methadone, what their discharge plan, where they're going to go for their care, all these numbers. And when it works the best when it's been seen and agreed upon by social work, anesthesia, OB, and substance use prior to entering intrapartum. And if the recommendations for pain can be on there or in the chart, it will decrease miscommunication. So even if people are not as well versed in the updated evidence on pain management, they could see it written in their chart, and then we'll tend to follow the recommendations. So it just makes things a little clearer. So the intrapartum experience, I'm gonna move through pretty quickly for time's sake. You can follow the American Society of Pain recommendations for managing acute pain and transfer them to a pregnant population. It works as long as you don't give ibuprofen. And agonist-antagonist treatment is not appropriate because it will precipitate withdrawal. So Stadil and Nubain are options for these patients in the intrapartum period. Some of the places where you can find the updated recommendations are ACOG's most recent position paper, and I would say SAMHSA's clinical guidance for treating pregnant and parenting women with opioid use disorders in their infants that was published, I think, in 2018, and it's very helpful. So it's worth downloading, and you can download it for free. There's only 4 studies that really address this issue, and most of those recommendations that I just showed are based in expert opinion. But what the studies have shown is that epidurals work for these patients. So offering an early epidural for patients when you don't have other options is very reasonable. They may have more breakthrough pain, but that can be managed. What we also find is that besides the vaginal delivery in C-sections, it's a little harder that's where we find the issues, where it's harder to manage their post-op pain. Typically, the vaginal deliveries can be managed with the routine pain protocols. And what they found is a PCA, and then transferring from there to a short course of oral opioid seems to work. I have 1 minute left. It's very sad. So I'm moving on to postpartum. Postpartum, this is where our problem lies, and you've heard it all day. It's where pain management deteriorates, and this is where we lose mothers. What we need to do is I will speed through this. You can take a look at all of this, but it's here. And then I would say this. If you learn nothing from any of these presentations today, this is the major take home, no matter if you're in the law or in social work or clinical. If you listen to women, if you trust what they're saying, and you strive to keep families together, we won't lose as many moms, and these patients, like every woman, deserve to be treated with respect and with, I think, care and collaboration with our patients. If we listen to them and we meet their needs, they're going to be better off for it. So, Godspeed.
Thank you, Jamie, and thank you for being cognizant of time. Just quickly, while we're bringing up the last presentation, there was one question over there for you, Jamie. So if we could just ask that question, because it'll give me a chance to pull up the next presentation, and that's the only question that we're taking at this time. Remember, if you do have other questions, please write them down so that we can get them to the presenter. So go ahead, lady in the maybe scrub top in the corner.
Do they go back to their regular Suboxone or methadone treatment within a certain period of time? Is that ever fluctuated against, or is that used in conjunction with other pain management?
Are you asking, like, in the third trimester, when they increase their dose, like, when do you have to go back down on it? The answer is listen to some ladies. They'll tell you. So if the patient, it really is patient dependent, and they typically will go back down to their normal course in the next few months after. But you'd be surprised at how well women can regulate their buprenorphine, especially. And I would listen to them, tell them, figure out how they're feeling, and then go from their symptoms, and you'll get them back down to where they need to be. But the worst thing you could do is under-medicate them, because when they start feeling cravings and the withdrawal symptoms, if you go down too soon, you'd rather stay higher for longer than go down too soon.
Thank you. Okay, our next presenter is Katherine Fornili. She is the assistant professor who has been a full-time faculty here at the University of Maryland School of Nursing since 2005. Dr. Fornili has a master's degree in public health and a doctorate in nursing practice in community and public health nursing with an emphasis in addictions nursing and public health policy. She has been a public health nurse for 36 years, yay. She has served in leadership roles in the city and state level, going from the White House to SAMHSA on policy panels and a part of that formation, and then also now to as the president of the International Nurses Association? Society on Addiction. Currently is the president of that group. Her interests include substance screening and brief intervention, pharmacological therapies, epidemiology of opioid use and consequences, health policy, and health disparities. Please welcome Katherine.
Thank you. So I have negative 13 minutes. And I'll try not to go too long, and I'll probably talk kind of fast. Some of this will be reinforcement of some of the major themes we've already seen today. But in reality, I didn't have access to anybody else's slides, and they didn't have access to mine. It's just, great minds think alike. So in my mind, the problem statement is that negative provider attitudes inhibit the ability to provide adequate services to patients with substance use disorder. And stigma and the mistrust of parents by health professionals increases the parents' feelings of shame and incompetence. They're counterproductive in the parents' recovery process, and it impacts adequate bonding between parents and babies. So there's 6 things I want to cover quickly today, and I'll skip the table of contents and go straight to them. I want to start with the working definition of recovery that was mentioned in someone else's talk today. It's a process of change. So often we want to turn on a light switch and have them go from drug use to recovery in one step, but it's a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. There's 4 domains of recovery that we need to focus on, not just the abstinence of substance use. And so we need to look at the holistic domains of health, including management of the disease process and their physical and emotional well-being. We can't get very far when people don't have a stable and safe place to live. And we need to focus on their purpose in life, meaningful daily activities like job, school, and parenting. And so much of what parents deal with in the recovery process are the relationships and social networks that do or do not provide support, friendship, love, and hope. And people achieve recovery better when they have positive, strong relationships. So the overarching principles of recovery are that recovery is a reality for millions of people. We tend to treat them like they're hopeless, but there's everyday examples of people who, like the two Rachels that we learned about today. There's many pathways and styles of recovery, so we can't just shoehorn somebody into our favorite model of care. We have to have individualized treatment planning based on comprehensive assessments, and we have to listen to moms to figure out what's the best pathway for that mother to achieve recovery. And recovery is a voluntary process. We can mandate someone to treatment, but the recovery process itself is voluntary and it's internally motivated. Patients thrive when they're in supportive communities, and recovery will give them back what addiction and mental illness took away from them. So, by the way, I'm the one with the bright slides, and I meant to bring the 3D sunglasses so you could have the full experience of this, but also it might keep you awake after that, lunch and cookies and all of that. But this is a really busy slide, and just don't try to take it all in at once. People go through substance use disorder services in the yellow boxes below along a continuum of care. We talked about prevention and treatment today, but let's say that prevention is on one side of the continuum, and that's where we try to intervene with people who have not yet developed risk factors or disorders. So that's like public service announcements and prevention education in schools. So those people have not yet been identified as being at risk. Early intervention is more like the screening and SBIRT, screening, brief intervention, referral to treatment. That's when you try to identify or detect a problem or a risk factor and intervene before the risk factor gets worse. For example, if someone's experimenting with drugs or binge drinking at a Ravens game, you want to try to intervene with people before they develop the full-blown dependence disorder. People who have dependence diagnoses require specialty addictions treatment. And this is where the big breakdown falls into, because we don't have a really good way of measuring the effectiveness of referrals, and we don't do the best job of providing access to people when they're ready to seek treatment. And so they may or may not take advantage of the treatment services that are available. And then the second place where this whole story falls apart is that we don't do a good job of providing ongoing, continuing care and recovery support following the treatment intervention. It's kind of like send you to 7 days of detox, 30 days of rehab, and we'll see you next time you relapse. And because we're not providing care to these, especially high-risk families with mothers and babies, we're not providing ongoing, continuing care and recovery support. So William White, the father of recovery management, identified 4 concepts of recovery management, and these include pre-recovery identification and engagement, recovery initiation and stabilization, sustained recovery support, and long-term recovery maintenance. And it's really the healthcare provider's responsibilities to help the mother or anyone with an addictive disorder navigate through the continuum and through these processes of change. So in recovery-oriented systems of care, the responsibility of continued contact falls upon the care provider and other service staff rather than the patient, but we like to blame the patients when they fall out of services. Pre-recovery identification and engagement is dependent upon a therapeutic alliance between the practitioner and the patient. So the practitioner has to have an awareness of a window of opportunity and a willingness to intervene with the mom. And the patient has to have the awareness that the healthcare provider is helpful and supportive and has that willingness to help them. And without that, they can't develop trust. Recovery initiation and stabilization is often seen to be failure or noncompliance on the part of the individual instead of the failure of the treatment system to initiate and stabilize the recovery. It's due to flaws in the service delivery system, not the flaws in the patient. The patient with addiction is exhibiting the symptoms that they're supposed to exhibit if they have the disease of addiction. You know, we try to moralize these ideas about patients. So sustained recovery support, I'm not going to get into a whole lot, but people need a wide range of services, sometimes called wraparound services, to provide them the kind of support that they need to eliminate their environmental or other barriers to treatment. And long-term recovery management just doesn't happen very often. And this is because we need to shift the focus from the service environment, like my treatment program or your hospital, and we need to shift this focus to the client's natural environment and see how they're doing in their real-life world. And so the theories behind this is kind of like Bronfenbrenner's ecologic framework of patient-centeredness, where the patient and the mother and the baby are in the center of a system of care. It's sometimes called the ecological onion because at the center is where the individual is, and all of the vulnerabilities and assets, their strengths, that the individual brings to the problem resolution efforts. My number 2 thing is that words matter. We talked about stigma today, and stigma is defined as the disgrace associated with particular circumstances, qualities, or persons. And so we're prompted by beliefs that the individual caused their situation, and the words that we use imply that the patient has poor moral character. And so when we start to use a cognitive framework involving stigma, then we develop cognitive biases that create systematic errors in our thinking, and these affect our decisions and judgments about people who use substances. And we would begin to demonstrate significant blaming and shaming and judging and use more punitive and more pejorative language. And when we do that to patients, then they internalize the negative stereotypes called self-stigma. And so the take-home message for today is that words matter. So for number 3, we don't have too much time to get into this today. I'm told I only have a minute left, but I've been trying hard to be a good timekeeper. I have 6 things I want to cover, and this is number 3, and I'll try to go real fast. We have to reduce wait times between when the patient requests service and when we actually get them to their first treatment session. We have to reduce no-shows by following up with people who miss appointments and providing the wraparound services that they need to get there, and try to increase admissions to treatment. And we know that if a person is able to get through their first 4 treatment sessions, they're more likely to have positive outcomes than if they miss the early appointments. And so, we have to invest more effort in people in those early stages. And part of the way we do this is create welcoming environments and a culture of quality improvement. And I'm kind of going to skip over part of this, but family engagement is so fundamental to the success of keeping families, retention of their children and keeping families together. So SAMHSA and the NIATEX program in Wisconsin did a study of 15 sites where they tried to improve the waiting time and improve the no-shows and also work on family engagement. And when you're able to involve the fathers or father figures and the non-residential children in the treatment care of the pregnant and post-parenting woman, then you can find more effective ways to engage them, then you'll have better outcomes, and it'll improve the mother's care of the other affected family members. And so this is a huge one too, and I wish I didn't have to hurry so fast, but we've already brought out that the majority of women in treatment today and most of the pregnant women who use substances, including opioids, have histories of sexual abuse, 74%, physical abuse, more than half of them, emotional abuse, 72% of them. They've had more instances of incest and rape, more domestic violence, and they've been abused by more perpetrators more frequently and for a longer period of time. And so compared to women who have either a post-traumatic stress disorder or a substance use disorder, women that have both a post-traumatic stress disorder and a substance use disorder will have more comorbid medical problems, more mental problems, more medical problems, more psychiatric symptoms, more inpatient admissions, more interpersonal problems, lower levels of functioning, poor compliance with their aftercare, be less motivated for treatment, and have more significant life problems and will be more likely to lose custody of their children. So what we have to really do is avoid re-traumatizing women. And every time a pregnant substance-using woman tries to interface with a healthcare provider, she either is at risk of experiencing re-traumatization or she is experiencing re-traumatization. So outcomes for women with co-occurring substance and mental disorders are improved when you try to adopt a trauma-informed treatment philosophy, and that would apply to labor and delivery, NICU, PICU, postpartum, prenatal, and aftercare. And women use substances to numb the pain of non-mutual, non-empathetic, violent relationships and to medicate the anxiety and depression associated with that. And when we have a trauma-informed care environment where we pay attention to things like our boundaries, we don't intrude into their personal spaces, we give them the right to say no to hugging, and we use empowerment language, they'll avoid being shamed. We avoid shaming and blaming them more and try not to be as punitive with them. And so sometimes female trauma survivors need to receive treatment in female-only treatment programs. If they're a victim of domestic violence and we send them to a co-ed treatment program full of men, they're likely to get re-traumatized or perceive threats of trauma. Fifth one is resistance and motivational enhancement. This is for you. We shouldn't push people into changing when they're not ready yet. Most people are not ready for change or not completely ready to change. And if they're not ready to change, we have to prepare them for change and help them move to the next level of readiness. This is the biggest lesson I got from your smoking cessation folks, that I was always trying to get people to stop smoking, and once I tried to just move them to the next level of readiness, I had improved outcomes. So how do we know when people are resistant? They interrupt you, they deny you, and since we're getting low on time, please everybody fill out your post-test if you have to split early. When people are interrupting, denying, ignoring, or arguing, this is signs that they don't feel like they're being heard, respected, or taken seriously. And we're inclined when people say but, or ignore you to push harder, but it's at that point that you need to step back and say, have I been pushing ahead without checking their level of readiness? And if we don't do that, we'll get into a confrontation denial trap with them. Well, they'll feel more tendency to argue, interrupt, deny, and ignore us even more. And then we'll feel propelled to push them even harder. And it's a circular trap. So people who show insight into the relationship between their negative consequences and their use of alcohol and drugs are probably going to be more receptive to treatment and do well in treatment. But people who can't recognize their problems, who fail to disclose that they have problems or exhibit denial and mistrust, will probably be harder to engage in treatment and more likely to drop out. I forgot that was in there. These people need to be assessed for treatment readiness and level of motivation. Motivational enhancement will improve their likelihood of success. So you can't teach that in a one-day thing. Please make it your adult learning, lifelong commitment to learning to try to learn the motivational enhancement approaches. And these are the stages of change. And again, I just want to say that the focus is on it's a better way of communicating with people. You think that they're hard to deal with, but when you learn this way of communicating with them, and you make the focus not on abstinence, but just on helping them move to the next level of readiness. Like if I don't have a problem and it's all you and I'm fine and it's just my boyfriend's fault, then if I try to say, let's go to treatment, and they're not ready, they're going to resist. But if we just say, look, it's your decision, it's your life, you know, when you're ready to get some help, we'll be here to help you. Just think about it. And they're like, oh, she's not pushing me to treatment. Okay, I'll think about it. And sometimes in one session, you can see somebody move from contemplation to preparation, just in agreeing to think about it, not make a commitment to change. That is a heartbeat, and that's an old slide, and I don't know why it's there. But we have to communicate respect, avoid argumentation, discuss their ambivalence openly while leaving them the, the decision maker about how they go forward with their treatment. And so the more, stop this thing. I can't stop it right now, but the more we incorporate advice about substance use with general health concerns and consequences, the better our chance of success. If you could. There you go. So this is my last idea for you guys. This is an old reference from 2001, but they've done a meta-analysis of 40 years of outcomes research, looking at what are the factors that were good at predicting positive outcomes. And they found that of all of these studies, I think it was 300 studies, the strengths that the patient came through the door with, their talents, their problem-solving abilities, their social supports, their beliefs, those were responsible for about 40% of the positive outcomes. The relationship factors, the alliance between the patient and the staff, and the patient's perception of empathy, acceptance, hope, and respect, that was associated with about 30% of the positive outcomes. And the extent to which the patient believes or expects that they can get better, and the possibility of experiencing change, and the ability of the clinician to instill in the patient the expectancy of hope, that's worth about 15%. So if you add all of them up together, 85% of the predictors of positive outcomes of treatment lie in patient factors and relationship factors between the patient and the counselor, nurse, physician, helper. And it's only 15% of the actual model Now, for pregnant women, I will say medication-assisted treatment is the evidence-based practice, and we do want them to be on methadone or buprenorphine for the safety of the mother and the baby. But really, the actual model, if it's cognitive behavioral therapy, is it aftercare, is it residential, inpatient, outpatient, that's only about 15% of the positive outcomes. So what I want you all to think about today is that all treatment outcomes can be equally effective, but they don't improve when we require patients to fit or conform to our favorite model. And so the biggest engine of change is the patient and the family, not us and what we do for them. And the outcomes will improve when we instill hope in them and accommodate our patients. So if you have questions, please contact me. And I'm going to let us move to the next speaker. Is it break or what? Okay, thank you so much.
Good. Do a break or no? Okay, so on the schedule, we're supposed to have break, but I think you all agree that we can keep going because we're almost at the end. And this is such useful information that, if you see the snacks out there, you might decide to just keep going. So let's stay in here. If you need to grab a snack, just grab it real quickly and come back right in whilst we load up the next presentation. Okay, so we're going to continue.
Okay, while we're loading the presentation, I just want to give an introduction to our last speaker. Very important to be able to take all of these great tools and things that we're learning today and put them in application to really serve the people that are in our community. So Joyce Gaynors is going to come to us and talk about community partnership, collaboration, and policy implications. Joyce holds a doctorate degree in higher education leadership from Morgan State University, and she serves as the president and CEO of the Family Recovery Program Incorporated, the only family treatment court in Baltimore City, Maryland, which was established in 2005. Her program works to decrease the time children spend in foster care through wrapping intensive services with family support, reunification efforts, and she has, over the past 28 years, she has gained experience and is an expert in addictions and substance use field. She is a certified counselor and has worked with adolescents, adults, and couples in both group, individual settings, and to help improve system functioning and increase family cohesiveness among those vulnerable, marginalized, and those individuals that are survivors of trauma. Through her work, she empowers thousands of individuals to believe in themselves and their capacity to change and to become self-resilient. So if you would please, let's give a nice welcome to Dr. Joyce Gaynors. And just for your information also, we have highlighted some of the bios from our great speakers today, but their full bios are also included in your packets. So if you want more information or want to know how to get in touch with them, you can find that information in there.
Hi, you're welcome. So, if you can start at 3:25. Is that good? It's hard. Yeah. 3:30?
Hello, everyone. I'm the last speaker of the day, so I know I have to be supercalifragilisticexpialidocious up here. I want to thank you all for coming today, and just for a point of clarification, my name is Jocelyn. So that's okay. I know some people call me Joyce sometimes. That's an easy mistake that's made, but my name is Jocelyn. I bring with me one of my parents. Someone earlier was talking about language, and the language that we use at the Family Recovery Program is not client. It is not anything but parent, and I present to you one of my parents. This is Miss Monique Knight. She just got off work like 4.5 minutes ago. So I thank the last presenter for giving us an opportunity, and that's her sweetie pie who just got out of school probably 6 minutes ago. So we're going to try to run through this. I was told we have until about 3:30, so we're going to skip over some things because a lot has been covered already. I'm going to talk first just a little bit about trauma, because I know you all have had a lot of talk, heard a lot of, and the Aquaja and I are really, really close. So this is how I do my work, right? So she's in my office, so she's here with me, so she's standing behind me, giving me a hug, giving me some support. So that's just how we do it, the Family Recovery Program. All right, so I'm going to go ahead and start here. So I just want to make sure today that we try to cover a couple things. We're going to talk a little bit about the burden of child removal, and Monique is really going to help me with that because she is someone who has experienced the burden of child removal. We're going to talk about what support looks like. We're going to talk about what FRP does, what we offer for our intervention and resources, and how we do it. We do it through collaboration and collaboration only. And throughout that, we'll talk about a variety of different lessons that we've learned. So here we are. We have a lovely picture of Monique. I don't think she's ever seen herself that large before. You should probably take a picture of that. She is a Family Recovery Program graduate. So throughout this, you will see the words FRP. That's just because that's what we call ourselves. We're just FRP. So she is a graduate. She's also a graduate of our SAGE Center. I'll be talking more about that later, but the SAGE Center is our housing unit for families who've actually lost custody of their children as a result of substance use, and they've come to us for extra love and support to try to get those children back and get support during reunification. And feel free to ask questions at any time, because I know this may be some interesting information that many of you all may not have heard before. So Monique has over 2 years of sobriety. We're going to give her a round of applause for that. She has and has had 2 jobs. She is the president of our alumni group. She has purchased a car, so she's going to actually be my ride back to work. She doesn't know that, but that's how we do, right? She's going to be my ride back. She has a tremendous savings account. I'm a little bit jealous of her. I think I need to take some lessons from her. She's working toward completing her GED. This has been an issue for us because she's a little frightened of the test. We actually have GED classes at our SAGE Center, which is our housing unit, and even the teacher has told us that he could not pass the test. So that's kind of scary, and so we're trying to figure out ways to work within that system. She also has very improved relationships with her other children, which she'll talk about briefly, and she's just an overall great human being. So I just present really quickly to you all Monique. I'm going to let her speak, though, as we go through our presentation. So just really quickly, because we're family recovery, we also deal with a lot of removal. And I chose this gentleman's picture here because this is kind of how the entire family looks when a removal happens. There is basic surprise, shock, and chaos. The children actually feel as though they've been kidnapped. Many of them want to know what's going on. They're very confused. They're just very frightened. The parents feel an immense sense of guilt and failure. There's a lot of confusion. There's just a lot of unpredictability. Monique, do you want to say anything about your removal and kind of how it impacted you?
My name is Monique, as everybody know. This is my little girl.
So,
2017 is when I entered in the FRP program and when they removed my daughter from my custody. And like this picture, it tells it all because I believe that's how both of us felt. No matter how much I might have been getting high, she still knew me and I knew her. So when CPS took my daughter, it was devastating, and a lot of it had to do with the fact that I didn't know what to do afterwards. And I'll explain a little bit more about what I did do, but just that moment of them taking her from me on both parts, on how devastated both of us was.
So this is the picture of our babies, and he is really going through some stress and strain, right? What we see when children are removed, it causes trauma. And I know we've heard that word over and over and over today, but it is real, my friends. The children very often are traumatized well before the removal. There's been substance use in the home, dysfunction in the community, and our babies are traumatized well beyond the removal. Yeah, you can say something, go ahead.
When she was talking about the trauma with the children, like with my daughter, until I started getting clean, I didn't realize that she seen me get high. So just like when I would go in the bathroom, and now that I'm clean and I go in the bathroom and she's right there at the door, like, what are you doing? And it just it doesn't dawn on us parents when we're out there, and we just think because we have our children with us that we're mothers, but not all the different activities that we don't know that they see. So when she got taken, I think with her, because she was only 2, she didn't think I was coming back. And nobody thinks about that when our children get removed, on how devastating it is to the children.
So just real briefly, when children know that their parents are in distress, they're in distress. And so many of our children feel like, who is this person? Who are these people? Kind of what's going to happen. They begin to cry incessantly. That same crying that you all saw from the baby that goes through withdrawal is the same kind of crying we hear when there's a removal. On toddlers, on our very youngest children, we see a lot of nightmares. A lot of our babies, when they get reunified sometimes, we see some of these behaviors still continuing. We see the whining and the crying and the constant clinging. We have daycare at our facility, and the parents are able to go to different classes right down the hall from where we do daycare, and sometimes the daycare provider just is like, I can't even take care of this baby because even though mommy is right down the hall, the child is screaming and can't be soothed. This is part of the trauma that our children have experienced. Many of our children, as they get a little bit older, begin to take it personally, and they begin to feel like they're failures, and they feel very ashamed and guilty, and I'm running through this. On some of our infants, we have a lot of sleep difficulties, and one of the things that we most see is the mood shifts. Many of our babies are very irritable. On younger children, sometimes we see them getting very passive, very quiet, and sometimes they just generally overreact to just gentle reminders of things that they have to do. You want to say anything, Monique? Nope, okay, good. All right. For our adolescents to get removed, they just have a lot of physical responses. They have a lot of self-injurious behaviors. Many of them are resort to cutting, and things like that. So you might say, with all of this bad stuff that goes on for families, what do families need to avoid those removals and to avoid that traumatization? And what we found that they need is support. And that comes in lots of different forms. Some of the support that we recommend first and foremost is natural supports. We encourage every parent to kind of look around themselves, look around their community, and identify what is in my community. Who do I have that helps me? Is it a mom? Is it a dad? Is it a grandmom? Many of our parents have burned their bridges, but there's always somebody who's willing to help them. So we ask them to find that first. We encourage 12-step meetings. We encourage any kind of 12-step. Marijuana anonymous, cocaine anonymous, you name it anonymous, we encourage it, right? Sometimes the parents can actually create relationships with the foster parents. That is a means of support. Also, church. One of the things that we try to encourage is a spiritual connection. We don't tell people how to do, what to do, but we do encourage that, because sometimes understanding that there's a power greater than yourself puts you in a good position to understand some humility. Social workers, sometimes they can be your friends, and I know there's some social workers in here. Our parents sometimes struggle with the social workers, but we really try to show them a different side and understand that something bad has happened. That does not mean you are a bad person, but there are lots of people that want to help you. The schools can help, as well as nonprofit organizations. And I listed 2, but guess what? There's a 3rd. So that is one of our families that actually graduated. That is our judge, Judge Kershaw, and he is there celebrating one of our graduates. That was about 2 graduations ago. So the Family Recovery Program is there to help. This is our mission and vision statement, and it's really simple because at FRP we see SEE, strengthen, engage, and equip our clients, our parents, okay? So we make sure that they have everything that they need to support their families. So I saw some of this in the prior slide, but this is also what we work on at the Family Recovery Program. We try to focus on health, home, purpose, and community. And I see the why kind of got moved down. But these are the things that we focus on because we understand how people get better. And it's when we focus on their health, when we focus on providing them a home, we're making sure that they have a good home. When they have purpose, right? People who are parents don't have visiting time with their children, right? We tell them, go enjoy parenting time with your children, right? There's no such thing for us as visiting time, right? Find your purpose. I'm sorry, Dr. DiClemente, you're going to have to help me babysit, okay? And community. So we like to tell them all about their community, show them who their community is. Like, Monique, we got a Wii donated just the other day, and Monique came to me and said, "Can we have a Wii party?" I said, "Yeah, we can have a Wii party. I'll buy the pizzas, you get the people." And she sent me pictures, I think it was last night, and they had a good time. I saw videos of parents dancing, children dancing, creating a sense of community, finding their own way in this world.
I want to back up a little bit. Like when she was talking about the Wii party and the pizza, you know, by being a recovering addict, one thing that it took me a long time to realize is how to have fun without the use of drugs. And a lot of parents, we don't know how to go somewhere and dance and cut up and without being drunk. And I used to think that I always had to be drunk or under the influence of something to enjoy myself. So when she told me about this Wii, and I'm like, you know, we are a community in Sage. And we just sitting there, and when, you know, like with me, I'm a robot. I get up in the morning, I get myself together for work, I get my daughter ready for school, I take her to school, I go to work, I pick her up from work, I take her to work activity. Sometime in the day I have to do a urine screen, and by the time we get home, we do nothing but eat and go back to bed. So that's really a boring life. I mean, I'm happy I'm clean, but I just wanted to, you know, show the community that we can have fun and we can have fun together. And something else she was talking about at the beginning about the different resources with the community. And one of the things that a lot of social workers and judges and counselors doesn't realize that, you know, when we get clean, that's like the easy part. The life on its own terms that would kind of like have a lot of people re-enter an active addiction, not having suitable housing. Because, you know, when CPS remove your children and you go to a recovery house and you get clean, then you still can't get your kids back because you don't have nowhere to take them. So I just really wanted to touch on that because that wasn't up there. And that's what a lot of mothers and fathers deal with getting clean and wanting your children back, but can't, you know, it stops it if you don't have suitable housing to take them to.
Okay, so Family Recovery Program is a family treatment court. How many people here have ever heard of Family Treatment Court? Probably, oh great, a lot, so that's exciting. So family treatment courts were created probably about 25 to 30 years ago, and Family Recovery Program is relatively new, however, we're one of the largest. There are about 500 family treatment courts across the country. Some are actually called Family Recovery Program, but what they do is all the same thing. They try to decrease the amount of time that children spend in foster care by wrapping really intensive services around them. So it was modeled after adult drug court. But we're a little bit different because we do not lock people up. So when people go to family treatment courts, we see several different outcomes. We see higher treatment completion rates. So our parents complete treatment more frequently. Our parents have children that spend less time in foster care. Our parents have much higher reunification rates, lower TPR or termination rates, and fewer CPS petitions after reunification. Our recidivism rate is about 8%, so we're really proud of that. We have lower CJ recidivism, and there's actually a cost savings for family because each family that is not in the system can actually help. Like Monique, she works, so she's no longer taking benefits and donations. She's taking care of herself. She's buying a car. She's doing the things that she needs to do. So who do these programs like mine work for? First of all, it works really good for people who have co-occurring mental health disorders, people who are unemployed, people with less than a high school education, a criminal history, poor housing, at risk for DV, and have used some of the drugs that we've been talking about today. We haven't talked about methamphetamine so much because that's a drug that hasn't gotten here too much, but this is who the program works well for. So this is what we have going for us in Baltimore. Also, people who have previous child welfare involvement. I'm going to skip that one. So what do we provide at FRP? So we are very, very comprehensive. So we have substance abuse case managers who work with the parents. They give them very intensive substance abuse case management. We have 24-hour drug treatment referral and placement. When a parent comes to us and they say that they need treatment, we like to think that we have a little red phone somewhere in my mind that we call when we tell people, you know, we need treatment immediately for this parent, and it happens for them. We also have immediate supportive housing. So we have contracts with housing providers throughout the city and the state where we send our parents. We have our own housing, which Monique will tell you a little bit more about later, where we have 23 apartments where our families can live. We have on-site mental health. We have a psychiatrist. We have a nurse. We have access to transportation, Lyfts and Ubers and bus tokens. We help with medication. We do on-site evidence-based programming, random drug testing, as Monique talked about, because even once you finish FRP, as long as you're still in SAGE, you still give me a UA once to twice a week. And we have an incentive store. You want to say anything about any of those things? Anything that help you the most?
What helped me the most, I've been living in SAGE, well, I've been clean for 29 months, and I've been living in SAGE for a little under, 2 years. And I can honestly say what helped me the most is structure. Even though, like, for instance, this morning, this is a perfect example of my life, doing everything that I do, and I had to go do a UA, but I also knew I had to be here. They closed at 5 o'clock, so that means I had to go and do my UA before I even went to work. But that structure, and I'm okay with that, and it got accomplished, and I made it here, thank God. But just like the different services, it helped me for the 2 years that I've been living in SAGE, because just being able to go, I have a case manager. No matter what I go through, I can go knock on this lady's door Monday through Sunday, because she actually works on Sundays too, and talk about anything, and they help us with everything. Like, in a sense, they kind of like hold our hands until we get strong enough to, walk on our own. And some of us need that, and they meet us where we are. They don't expect us to be up here if we're down here. So it's a really great program, and I'm happy to be a part of it.
We also make a lot of referrals to agencies that focus on life improvement. We write a lot of reports. Every week, the judge needs reports. So we write reports to the judges, to DSS. We have the alumni group that Monique is in charge of. We have a lot of educational opportunities. Like I said, we have a contract with BCCC to do GED. We really love our peer recovery advocates. If you don't have one where you work, find a way to get them. They are folk who have actually been through this thing called recovery and sometimes child removal, and they help our parents immensely. Some of our peer recovery advocates actually go to like healthcare for the homeless and stand in line with parents at 5 o'clock in the morning. Things that my case managers cannot do. Parents need support. They're afraid. They don't know how to do certain things. So the peer recovery advocates come in and help. We work with CASA, and what we also provide primarily is opportunity. This is a not so clear picture, now that I see how large it is, of the Harrington at Weinberg building at Sage Center. Sage was a vision of mine. One moment, sweetie. Sage was a vision of mine from a long time ago. I just kept looking at the parents in the family recovery program, and I was saying, what is it that they need? What is happening? Why aren't the parents getting the children back any quicker? And it wasn't happening because one of the main barriers was housing. How do you expect people to afford housing in Baltimore City? $900 is the median rent for a one-bedroom apartment. And if you've seen what some of those look like, you would not want your family or friends living there, much less anyone that you serve. So I found this lovely school that was unoccupied and was owned by the Archdiocese, and I made a deal with them, and they made a really good deal with them, and we were able to purchase the building. Then it took me about 5 years to work out how to find $7 million, but I found $7 million, right? $1 at a time. Let's give a round of applause, right? That's a lot of money, right? $1 at a time. And when I finally had all $7 million, we were able to start. And so we renovated Sage, which was a 28,000 square foot school, into a 23-unit apartment complex, 18 2-bedrooms, 5 3-bedrooms. We were also blessed to get Section 8 for 8 of the units. So Monique is raising her hand, right? So that is huge, because what happens is this project-based Section 8. And what that means is our parents get to come in, those who are so lucky, and they get to take this Section 8 with them when they go. And I still get to keep it. So when Monique leaves in the next couple weeks or a month or whenever she leaves, she will go out on a Section 8 voucher, which will probably help her for a very long time. And then another young family will get to come in and stay in that same apartment. That's after all the pink is gone, because it's really the pink palace. Right? So this was 400 friends of mine, right? Family, friends, I don't know who all these people are. We had to build a playground, and I had about $5,000 for a playground, and I said, that's not going to work. I need a lot more money than $5,000. So work with Kaboom. You all may know about Kaboom, but they make you get volunteers, and so we had to get 400 people. Kwaja, have a seat, please, sweetie. Thank you. So we got 400 friends together, and they built us 2 playgrounds for our babies, and the playgrounds stand to this day, and the kids still have fun on it. So I'm supposed to talk really quickly about how this thing works. And so the key to our success is partnerships, right? So we have tons and tons of partners. This is a small list of the partners, but the Health Department, Behavioral Health Systems Baltimore, DSS, Family Tree, Child and Family Services. We also have a family treatment court in DC that we run. We just were awarded a second 5-year contract, so we're thankful for that because we have employees in DC who are trying to change the lives of children through that family drug court. We work with the police department. We actually have a farm near us that delivers food a couple times a week, and we work with them. Just a humongous amount of partnerships. So in order to create those partnerships, because this is the only way I actually do what I do, is I just enter into people's lives with openness and trust. I try to create relationships. One of the things we really focus on is how to have agreed, shared values. You know, both of us want the same thing. How can we both accomplish the same goal? Regular communication, so we talk with our partners regularly, sometimes weekly, and we have what we call intentional follow-through, right? So we make sure that we follow through with all the things that we're prepared to do. We create a lot of MOUs and MOAs, and we do pay for services, so sometimes that helps. Keeping it moving, that's just a certificate that we got there. We get lots of certificates. That's one from the foster grandparents. We have a partnership with them. They provide our free daycare, so I don't have to pay for it, and our parents get a chance to go to group and have fun and do all kinds of good stuff, and daycare is right there on site. So policy implications, just really quickly, there was something passed, the Family First Prevention Services Act. It was actually signed in a little bit earlier this year. And what it does is it actually reforms child welfare financing. And so what we're hoping to do is take a part in some of that by offering what we call our Horizon program, which is our prevention program. So that allows people who have actually not lost custody of their children to come into the Family Recovery Program and receive really intensive services. We've had a Horizon program for a very long time, and we have parents who actually live in Sage who actually did not have their children removed. They just needed extra support, and DSS made that referral, and we wrapped those services around them. And so to move the needle, what do you have to do? You have to constantly support these vulnerable families, partner with organizations, try to be open-minded, pay attention to the legislation, because follow the legislation and you will follow the what? The money. That's absolutely right. And just be a part of the community. You know, this is a real family thing. I love the name Family Recovery Program because that is what we do. That's who we are. We focus on families and fun. And what I didn't say is we also have a lot of men. So we don't deal with just women. So I know a lot of programs in Maryland just deal with women. We believe that family recovery should be just what it says, family recovery. So we work with parents. We work with dads. I was just talking to Dr. DiClemente. We've had a lot of dads come in where there is no mom. And so at Sage, we actually have one dad who has his two daughters. We have another dad who'll be moving in a couple of days who also has children. So we make sure that, you know, people are respected for who they are and what they bring to the table. And so with that, I close. I think I made my 3:30 mark. I put on roller skates for you guys. I'll take some questions now if you have any. There's one? Oh, okay, great. Oh, thank you. That means the world to me. I appreciate that. Question? So, are you in Baltimore City? So, all you have to do is tell the parent to go to DSS and get a family pres worker. Once they get a family preservation, and I shouldn't use the acronym, family preservation worker. If they get a family preservation worker, they can actually make a referral just by calling our office. And at that point, they'll get in touch with one of my employees who will then access them to all the services and fun. And this is also some fun we just had. Another graduation, one of the parents we were singing "Oh Happy Day," and that's a grandparent. She was really happy. It was a happy day for her. So we are also available for tours, so if anybody ever wants a tour, I have my contact information. I'm sure Doris has it for anybody that may need it, because I did not know how many people were going to be here, and I don't have but about 5 cards. So, but just remember, together we can do it, and we're always available to kind of talk, help people kind of move through this thing called recovery and families together, just because we are committed. We've worked with Dr. Clemente. We know how important this work is when we want to continue to be here. Family Recovery Program has been here 15 years, and we've had over 1,500 families that we've impacted, and we have an 87% permanency rate. Everybody say 87%. That's right. That's some good stuff. What that shows you is that with support, families can do it. Okay, other questions? Nope. Okay, I think Doris, Dr. DiClemente, go ahead. Yeah, Monique, he knows your story, so you know.
Well, I have 5 children, actually. My oldest son is 23. He lives in Texas. He works at Amazon. We have a beautiful relationship. I have a 20-year-old son that lives in Texas also, and he's in the Army. And I have a granddaughter by my 20-year-old son. And I have 2 twins. They're 19, boy and girl, and they live in Virginia. And I have also had CPS involvement when they was younger, and they all got taken from me numerous times because in my mind I was young and I couldn't stop, and having, fun or whatever. But from what I'm doing currently and them seeing me stay clean, they are all a part of my life. I've actually had a chance to go to Virginia and North Carolina over the summer to visit, to meet my granddaughter, to attend a baby shower. Like, we stay in communication a lot, but children, they still children. They like to text, they got the iPhones and all that. So I text them good morning, I text them good night. And my children, all of them have said to me, as long as I take care of her, they're fine. And just by showing up, being there when they call, answering the phone, their kids are very smart. That's another thing that people don't realize. When mom and dad change, they know. And, and it feels really good to be able to be present in their life.
So there's my contact information if anybody needs it. And our website, and we are a nonprofit, which means we do accept donations. There's a donate button at the very top. I say that all the time because that's how we make money. That's how we live, right? I'm not too proud to beg.
Thank you so much, Dr. Gaynors, and thank you for all the work that you were doing. Okay, so quickly, we are in our final stage of the workshop, our roundup and call to action. And quickly, Dr. Wiseman is going to come and she's going to give us the quick wrap up and call to action. She is currently the chair of the University of Maryland School of Nursing at the universities at Shady Grove. She has worked with 16 full-time faculty and 6 full-time staff members. Over 320 students are currently enrolled in the BSN, RN to BSN programs and the family nurse practitioner programs. Dr. Wiseman is a member of the Committee for Interprofessional Education, and she works with over 80 programs that work with interprofessional projects. She's on many workforces, and she is working with various stakeholders and multiple projects such as focus in the pipeline of students and educational challenges and practice to reality. So we know that she has a professor background, so she's going to give us a wrap up and give us something good to go home with.
I'm not so sure about that. I said you could just skip me and it would be okay, but they wouldn't skip me, so here I am.
No, I cannot skip.
So I think the afternoon part was amazing. We learned about different programs and different things, and it's not my area of expertise working with mothers to be. I'm a med-surg nurse, and but it's an incredible experience having been here today, so I really appreciate learning, because what I've learned today can be used across any discipline. It doesn't have to be maternity. It's learning how to work with people who have a problem. So we started our day learning about opioid misuse and putting the issues in context. And data show that maternal opioid use seems to be higher in younger women. And this indicates that we need to start prevention and awareness training early in elementary and middle school. In the Northeast, we learned that there is a high incidence of MOUD, but lower medication-assisted treatment, and that is a terrible thing. we need to be focusing. I think you saw the acronym, it was MAT, Medication-Assisted Treatment. We heard Dr. Polsky report on the Healthy Behaviors Program in Calvert County. And when we heard about his program, it made such sense. And we probably asked ourselves, why isn't everyone else doing this? But then we learned that it isn't happening. It's probably just happening in Calvert. And we had a very complex case presentation. And we learned that things were pretty fragmented and uncoordinated in our care of people. We also heard from Dr. DiClemente that the secrets of success are collaborate, communicate, and integrate. And those are the three words I'm taking away from here. Collaborate, communicate, and integrate. And so we could stand here as an interprofessional group and we could say, woe is me, this is complicated, it's very complex, and we might feel a little defeated and a little resigned that, how are we going to change these big systems? We can learn from successful examples and work to do that collaboration, that communication, and that integration, and look at what's happening in Calvert County. Not much money, but a lot of coordination. And we can coordinate anywhere. And I'll give you a quick example. I hadn't planned to say this. I used to be the director of the Governor's Wellmobile program. It's mobile health units that go across the state. I had 4 of those across the state. And one of the things I learned was go and work with your partners in the community. There are people there doing amazing things. You don't know it. You need to go find out about who they are and what they have to offer, and then collaborate with them and work with them. Everyone in this room is doing amazing things. You don't know each other. You need to learn about each other. And we can recognize there are multiple programs and approaches, and that by working across, through, and within our disciplines, we can develop better approaches and better care for our people in our state. Thank you.
Okay, so we've come to the end of our program in a few minutes or so. There's so much that we have learned. There's so much that I have learned. And what comes to my mind is here we are. Here we are, healthcare providers. We've come together to talk about the issues. And issues that, we've had trouble wrapping our mind around, issues that others have found a way around, issues that we're starting to think about. So where do we go from here? I think for next steps, I think we would like to come together again. Don't you agree? In whatever forum. And maybe immediate next steps will be forming a listserv where we can all share some of this information, share some of the best practices and strategies that have been given to us today, share what practice is actually doing, because, for some of us who've been out of practice for a while, there were such insightful things that we learned today. So, we would propose that we start off with a listserv, and I think we have your permission to start an email listserv going. And we plan to have brown bag seminars. Each team that you see is expected to have a brown bag seminar based on a topic of their choice. So if that information comes around, even though it's in the UMB campus, we'll post it widely so you can all participate in it. So they'll feature these topics, and we'll have webinars. We won't just sit in the listserv, we will do something, right? We will share the information and then have webinars. So we continue to educate ourselves, because what we're building is this collaboration and communication and integration, which we've all agreed that it's so important towards managing the treatment of mothers and pregnant women with opioid use disorder. So we do have our marching orders. Dr. Wiseman has set the stage very well for us. The presentations, some of them will be downloaded at the registration site, so you can add it to your list of resources. We will continue to update you with what we find, because, that's the way we also learn. We have to find out what evidence-based practice is out there, what practice is doing. So it's really very key to everything that we do, that we pay attention to resources and white papers and reports that are coming out and recommendations, in addition to what we have to contribute. I would like one word about the CEUs for nursing and pharmacy. It takes about 30 days for your folks to process, so expect your certificate in about 30 days. Social work is outside the door and waiting to hand you your certificate when you leave here, okay? So make sure you pick it up, and make sure your name is on the list. You've registered, you have a packet, everything you need to know, okay? So having said that, I would like to thank everyone on behalf of the interdisciplinary team. You know who we are. We came from nursing, medicine, law, social work, and we're welcoming any other discipline that would like to join us, because we would like to make this truly collaborative and communicative and integrative as well. Okay, so we would like to thank the speakers who gave us such wonderful insights. We won't forget them in a hurry, not at all, I know that. We want to thank the panel for the collaboration and understanding of each other, and in talking about a really, really difficult case that had so many, just, I want to say, tentacles to it, and they tackled it very well. We also want to thank the keynote speaker, Dr. Clemente, for taking the time to spend the day with us. We're so honored. And then, of course, we want to thank the patients for taking the time after work to be here. I mean, that's awesome, and, we thank you very much. So on behalf of the team, we thank all of you for coming, all of you for participating, and take we have apples out there, we still have your snack that is out there, so take something with you, okay? And if you need to reach out to us, my email address is on the registration website, and please fill out the evaluation forms, post-test forms. I mean, it's kind of late to take the pre-test, but, okay? And everybody have a safe travel, safe journey back where you came from. We thank you all very much.